So, ladies and gentlemen, let me complete the sessions that we're going to have on cardiac development and continue the process. What do we need to know when we consider the outflow tract? I've already introduced you to the outflow tract, and I've told you that initially during development, all of its walls are myocardial. So the question I'd like to consider with you in this presentation is, how does that myocardial outflow tract remodel such that the systemic and the pulmonary pathways will have primarily arterial walls, with very little myocardium persisting in the left ventricular outflow tract, although the right ventricle does have a completely muscular infundibulum. So those are the processes I'd like to consider with you during this final embryologic session. And I'd like to introduce you to this important statement. You can read it for yourselves, but the key I want to bring to your attention is the fact that the author of this statement has emphasized the rapidly changing shapes and locations in which the components of the outflow tract are found at different stages of development. And I'm going to show you that this is absolutely the case, but this is far from new. In fact, this statement comes from that of Theodore Kramer, and it's published a long time ago, 1942. And 1942 was an important year, not only because Kramer published this important paper on development of the outflow tracts. It's very important for me because that is my birth year. So I am as old as the paper published by Kramer on development of the outflow tracts. Now, what was the point that Kramer wanted to make about these rapidly changing shapes and locations? He suggested that to produce clarity in our understanding of development, we should describe the developing outflow tract in terms of the truncus conus. And I'm sure the majority of you still talk about conotruncal malformations. Well, I have problems with that account because, as I'm going to show you, when you think of the truncus and the conus, it doesn't take account of a key third part of the outflow tracts. So does considering development in terms of truncus and conus help in appreciating the definitive arrangement? And I'd like to suggest to you that that in fact is not the case, and we can now give you a much better means of understanding the development of the outflow tracts. And to do that, I'd like to go back and look at the anatomy of the postnatal outflow tracts, specifically in this picture, the outflow tract of the developing right ventricle. And what you can see is that the outflow tract of the postnatal right ventricle has at its starting point an infundibulum. The infundibulum is supporting the pulmonary root, and then beyond the pulmonary root to the margins of the pericardial cavity, we have the pulmonary trunk. And beyond the margins of the pericardial cavity, we then have the right and left pulmonary arteries. And in the neonatal circuit, we also have the arterial duct. So if we think of the components of the definitive outflow tracts, over and above the extrapericardial arteries, we have the intrapericardial arterial trunks. We have the arterial valves and their supporting valvar sinuses, and we have the ventricular outflow tracts. And in the postnatal heart, each of these components has its own walls. And that means that in the postnatal heart, within the outflow tract, there are no septal components. But what I'm going to show you is that there are structures during development that septate the initial outflow tract that had a solitary channel supplying both the systemic and the pulmonary circuits. So how can we explain the remarkable changes that change this channel that has a common outflow tract into the systemic and pulmonary pathways. And how can we correlate that account, which separates the lumen into pulmonary and systemic channels, also to account for the formation of the arterial roots if we only think of it in terms of the truncus conus. So that is what I'm going to try to show you, how the common lumen becomes separated into discrete channels, albeit without any persisting septal components. So I'd like to start again at the beginning. I showed you this in my initial presentation to you, where the linear heart tube initially makes up predominantly the left ventricle, but with growth from the second heart field, we have an outflow tract supporting the ventral aortas. And we've already discussed how the key stage of development is formation of the ventricular loop, but at its initial stage, the ventricular loop receives the atrioventricular canal at its inlet and supports, at this early stage, the entirety of the outflow tract. So here is the outflow tract as a solitary channel with a common lumen. We've seen that the next stage is ballooning to give the developing left ventricle from the inlet, developing right ventricle from the outlet of the loop, with the outflow tract supported exclusively by the developing right ventricle. And this is the stage that I'd now like to discuss with you in greater detail. The stage that we start off, where we have an outflow tract with a common lumen supported exclusively by the developing right ventricle. Now, at this early stage, there is significant logic for considering it to be bipartite, because it does have proximal distal parts, with the distal part extending to the margins of the pericardial cavity. And there at the margins of the pericardial cavity, we see how the cavity, the distal outflow tract, becomes confluent with that of the aortic sac. And I have shared with you already the changes that take place in the aortic sac. We'll consider that again when later we discuss vascular rings and slings. But at this stage, I want to specifically concentrate on what's going to happen on the relationship between the aortic sac and the distal outflow tract. So beyond the margins of the pericardial cavity, the distal outflow tract becomes the aortic sac, but the key point that I want to emphasize again, midway through the 5th week of development, the entirety of the walls of the outflow tract are myocardial. And I've shown you this picture before, I show it again. It confirms that at this early stage, the outflow tract has proximal and distal components, but the key point I want to make, all of the walls are made of myocardium. So the key to understanding is the so-called regression of that distal myocardial border. And this occurs by the ingrowth of still further tissues from the heart-forming fields into the arterial pole, but these ingrowths are non-myocardial. And it is the ingrowths of these non-myocardial tissues that will give us the arterial components of the definitive outflow tract. And as this starts, and as we look at this distal regression, initially we see it occurring in fish mouth fashion. Now, what do I mean by fish mouth regression of the distal myocardial border? We can see that in this reconstruction of the developing heart from human embryo at the beginning of the 6th week of development. So 36 days passed here in Carnegie stage 15, subsequent to conception. And that little brown ring you can see at the top right-hand corner, the top left-hand corner of your image is showing us the pericardial reflections. So that is the level where initially the wall of the outflow tract became confluent with the wall of the aortic sac. And initially, as I've shown you, that wall was exclusively myocardial. Now it is the paler green that is now showing you the myocardium that is enclosing the wall of the outflow tract. And what you can see is that its distal myocardial border has regressed away from the level of the pericardial reflections, and it has done so in fish mouth fashion. You can see how the green parts are like the jaws of the fish mouth, and they are now away from the pericardial borders. What you can see in brown is something that is growing in to separate what will become the intrapericardial aorta from the intrapericardial pulmonary trunk, and that is the aortopulmonary septum. And that has grown in from the dorsal wall of the aortic sac. This is what it looks like as we see it from the right side. We can take this same reconstruction and we can rotate it round so that you can look at it from the left side. Again, you see the level of the pericardial reflections. The light green area again is showing you the myocardium, the outflow tract, and just as on the right side, there has been fish mouth regression of the distal myocardial border on the left side, and that is giving us the wall of the intrapericardial pulmonary trunk. And now, as we look at it from the other side, we can see how the aortopulmonary septum is separating what is going to become the pulmonary trunk from the intrapericardial aorta. I can now show you that process in a frontal section through the heart at the comparable stage of development. In fact, things have gone just a little bit further. We're now at the beginning of the 6th week of development. You're looking at it from the front. So you can see now that those walls have grown in to form on the right side the intrapericardial aorta, which is now separated from that growth from the dorsal wall of the aortic sac, the aortopulmonary septum, from the intrapericardial pulmonary trunk. Two other structures have appeared by this stage from the ends of those tongues of non-myocardial tissue that have filled the space in that fish mouth regression. And these are what we're going to call the intercalated valvar swellings. In fact, these components were first described by Kramer in that seminal work in 1942. So much of what Kramer said was very important. But what I'm going to show you is it's the formation of the intercalated valvar swellings that permit us to understand how the outflow tract has 3 rather than 2 parts. Because the remainder of the outflow tract is being separated by the outflow cushions. We've already seen these building a shelf in the right ventricle so as to commit the aortic root into the left ventricle. We're now going to be concerned with the distal part of these outflow cushions, separating the middle part of the outflow tract to give us the aortic and the pulmonary roots. But before that can take place, the aortopulmonary septum has to fuse with these outflow cushions. And we can see the process of fusion in this mouse heart. Here I'm showing you a picture I've cut away to show you through the intrapericardial aorta. There are the distal outflow cushions that are coming side by side to each other to separate the more proximal aortic channel from the pulmonary channel, but at this stage, prior to fusion of the aortopulmonary septum with the distal cushions, there is an aortopulmonary foramen. And it's persistence of that aortopulmonary foramen that explains the aortopulmonary window. But in normal development, that foramen is closed. And it is closed by ongoing growth of that aortopulmonary septum, which initially originates from the dorsal wall of the aortic sac. And with closure of the aortopulmonary foramen, so that myocardium continues to regress, giving us intrapericardial trunks, each with its own arterial wall, because the non-myocardial tissues growing in from the second heart field have replaced the myocardium in that initial fish mouth regression. And once that has taken place, the aortopulmonary septum also remodels so that there is no longer an aortopulmonary septum. And we see that here in the 13th day of development. In the mouse heart, there is the intrapericardial aorta, the intrapericardial pulmonary trunk. They have now separated one from the other. So what started off as an aortopulmonary septum is no longer a septum, because the intrapericardial trunks have developed their own walls. So, towards the end of the 6th week of development, that distal myocardial border is at the level of what eventually will become the sinute-tubular junction. So now I need to return to the formation of those intercalated valvar swellings, because it is the appearance of those swellings that permits us to divide the outflow tract into its 3 definitive parts. So here we see the situation as we begin the 7th week of development. We're looking at it from the right side. Now the intrapericardial aorta, the intrapericardial pulmonary trunk have developed their own walls. The light green is still showing us the myocardium. And the myocardium now has both a middle part and a proximal part. But how do we know there is a middle part? We know that when we look inside it through a transverse short axis section. First, let's look at it in a frontal section. So this is the stage that's happened at the beginning of the 7th week of development. The distal component by now has been separated into the intrapericardial aorta, the intrapericardial pulmonary trunk. The proximal component has still to be separated, but within the proximal component, you can see the outflow cushions that have yet to fuse. But our attention now needs to concentrate on the distal part of that has retained its myocardial covering, because we can now recognize that as the middle part of the outflow tract. And that is because the aortopulmonary septum has fused with the distal part of the outflow cushions, themselves also having fused together. And there, within the middle part, we have the intercalated valvar cushions. So if we take a cut across this middle part, and now we look at it in its short axis, we can see why this situation has produced us the primordiums for what will become the arterial roots. This is a mouse heart again. I've cut through the outflow tract in its middle part, and I'm showing it to you as seen from above and from the right side. It still has its myocardial walls. But in the center, the cushions have fused with each other. More distally, they've fused with the aortopulmonary septum. So they've separated the central part into what will be the aortic and pulmonary roots. But more peripherally, the cushions have not fused. So these unfused peripheral parts are now interdigitating with the intercalated valvar cushions, and it is that interdigitation which on the one side gives us the developing pulmonary root, on the other side gives us the developing aortic root. And we can take a human embryo and we can cut it in oblique subcostal fashion again, and I can show you exactly what is now happening in the middle part of the outflow tract, because we're cutting the aortic root almost at right angles to the pulmonary root. They both at this stage retain their myocardial walls, but the cushions are excavating, having fused centrally, to give us the leaflets of what eventually will be the pulmonary valve anterosuperiorly, the aortic valve postero-inferiorly. So those arterial roots are formed within initially a myocardial turret. The leaflets are formed by excavation of the outflow cushions, and then there is ongoing regression of that distal myocardial border with still further material coming in, part-forming areas, to form the walls of the arterial valvar sinuses. And they then separated from each other, so no longer is there a septum between the arterial roots. So what happens in the proximal outflow tract? You've already seen that because I showed it to you with regard to ventricular septation. So let's return to this picture that you've seen before. And it all depends on what happens to these proximal outflow cushions. Distally, the cushions have separated the pulmonary from the aortic root. All the blood at this stage coming into the roots is coming through the secondary interventricular foramen. And I've shown you this before, I repeat it again. It is the fusion of the outflow cushions, the parietal cushion, the septal cushion, coming together that separates the aortic root from the cavity of the right ventricle, committing it through the secondary interventricular communication with the left ventricle. And then it is the muscularization of the shell of those proximal cushions that forms eventually the freestanding subpulmonary infundibulum, separating itself from the aortic root with closure of the aorto-right ventricular communication, putting the aortic root into the left ventricle. So it is separation of that muscularizing shell that will give us the freestanding subpulmonary infundibulum. So how do we explain development of the outflow tract? We explain it in tripartite fashion. We have a proximal part, we have a middle part, we have a distal part. And then, margins of the pericardial cavity, we have what initially is the aortic sac. With ongoing development, those components of the aortic sac will become the extrapericardial arterial trunks. The distal outflow tract will become the intrapericardial arterial trunks. In the middle, we will have formation of the arterial roots with their supporting valvar sinuses, and the proximal part will become the ventricular outflow tracts. So what I hope I've shown you in the 4 sessions I've given you on cardiac development, and now particularly in this final session concerning with the outflow tract itself, development can now be well understood. But with regard to the outflow tracts, we need to adopt this tripartite fashion, but we need to recognize what is going on in the extrapericardial pathways. Sorry for that additional U. And I'll discuss that with you when we talk about vascular slings and rings. But for the outflow tracts itself, we need to adopt this tripartite approach, because only in that way can we include the arterial roots. Thank you all for listening to my sessions on cardiac development.
Thank you so much, Professor Anderson. That was another amazing illustration of using human and mice embryos. As I had said at the start, for those who weren't here, this was Mike, so we don't have to pass around this mic. I'll start off the questions if I could. We have several fellows in the room. It seems like the structure you've given us in terms of development are nice shoulders to stand on in terms of talking about the common arterial trunk and failures of septation of the outflow tracts. Would you able to briefly kind of provide your perspectives on common arterial trunk and how that nomenclature developed?
Indeed, I should also apologize for everybody in suggesting that this is my final session, because I realize that in fact we're going to have another developmental session tomorrow when we'll talk about the functionally univentricular heart. So excuse me for getting my 4 presentations one out of order. Sorry for that. So it's a very good question as to how do we explain common arterial trunk. I showed you a very nice picture, at least I think it's a very nice picture, in which just prior to fusion of the aortopulmonary septum with the distal part of the outflow cushions, we had an aortopulmonary foramen. Now, if that does not close, that explains the aortopulmonary window. And I think you all know that an aortopulmonary window is separate from common arterial trunk because in the aortopulmonary window, we have separate arterial routes. And I hope that picture I showed you of the persistent aortopulmonary foramen can explain to you why you can have fusion of the outflow cushions distally, giving us the separate arterial routes, and yet still have a persistent aortopulmonary foramen, giving us an aortopulmonary window. So what is the difference between that and common arterial trunk? Well, the difference, of course, is that in common arterial trunk, it is the outflow cushions themselves that do not fuse. And then it is the extent of growth of the aortopulmonary septum that separates the intrapericardial component of the common trunk into its aortic and pulmonary components. But the fact that the cushions themselves have not fused mean that we retain the common ventricular arterial junction that is the essence of the common arterial trunk. So it's as simple as that. And as I mentioned yesterday, Lodewijk van Meerop, the guy who put together the archive at University of Florida that Diane curates, Van Meerop explained all of this in the late 1970s in a colony of caisson dogs. And he showed exquisitely that these caisson dogs had common arterial trunks. He looked at the developing puppies prior to birth and showed without question that it was failure of fusion of the outflow cushions that explained common arterial trunk. We've now repeated that in colonies of mice, perturbed mice, genetically perturbed mice with knocking out genes. And by knocking out several genes, particularly TBX16, we've been able to produce common arterial trunk and show unequivocally that the common arterial trunk is the consequence of failure of fusion of those outflow cushions. So it's as simple as that.
A couple of questions, please. So, Anderson, just like you mentioned yesterday that it's possible for the common arterial trunk to exist without a VSD. Is it possible for that to exist with septation or separation of the aorta and the pulmonary artery then?
Indeed, and that is you make a very good point there, because in fact I overstepped the mark a little by saying that it was failure of fusion of the cushions that always explains common arterial trunk, because you can, in fact, have common arterial trunk very rarely when the cushions have fused, but have then applied themselves to the crest of the ventricular septum, and that is the very rare variant that. Did you show them the pictures of the fetus you had, Diane, with that variant yesterday, or are you going to show them that today?
I have those specimens today.
So Diane will show you an example today where the cushions, the outflow cushions, have in fact fused, so they've separated what ought to have been a common arterial junction into its aortic and pulmonary components, but the cushions have then fused with the crest of the muscular ventricular septum, meaning that the defect that we see at the margins of the ventricular septum is only permitting shunting at arterial level. And we've made the comparison between a ventricular arterial septal defect as opposed to an atrioventricular septal defect. So they can fuse, but when they do that, they fuse with the crest of the muscular septum, taking out what ought to have been the ventricular septal defect, but still leaving an interarterial septal defect. And Diane will explain that to you, I think, when she shows you the specimen.
Then my second question is, in the pictures you showed of the embryo, both the developing aorta and the pulmonary artery have the same orientation. Like when you see the cross section, you can see down the barrel of both these vessels. But at some point they twist, they spiral. When does that process happen?
Well, in fact, the axis of the pulmonary trunk, you have my recordings, so you can go through them again. But if you look at the axis of the pulmonary trunk is going from anterior to posterior. The axis of the aorta is going from caudal to cranial. So already at what will become the sinutubular junction, the axes of the two arterial trunks are themselves almost at right angles to each other. But it's when you put all three components of the outflow tract together that you get the spiraling arrangement. So when you also look at the arterial roots themselves, they are almost at right angles to each other. And then the outflow tract from the right ventricle is that really spirals around the aortic root rather. So the greater part of the spiral that you see in postnatal life is seen between the infundibulum and the aortic root rather than between the arterial trunks themselves. The arterial trunks themselves are at right angles to each other, but the greater part of the spiral is seen when you put all three components of the outflow tract together. And Diane, do you still have a normal heart with you?
Yes.
So you can show them that. I think that's perhaps the point to make, is to show them how the spiraling comes into effect and how the pulmonary trunk is more or less at right angles to the aorta, with the pulmonary trunk going from front to back and the ascending aorta going from top to bottom.
I have a follow-up question to Ashok's. Bob, on that same cross section, you showed very nice commissural alignment between pulmonary valve and the aortic valve, and we all know that that's not always the case, especially when the relationship of the two to one another is abnormal, such as in transposition. And then clinically, we often use that as a marker to be on guard for other trouble down the road, like unusual coronary artery origins in a patient with transposition. Can you speak to, how they become malaligned and why that spells trouble sometimes?
It's a very good point that you make there. I mean, the picture that I showed, the central part was still solid and the two roots had not separated themselves one from the other. And at that stage also, the cushions are still essentially adopting a septal function. And it's as they separate one from the other that you get a degree of rotation between the roots. And you can imagine, as the pulmonary outflow tract separates itself from the aortic outflow tract, there's quite a lot of remodeling that takes place between what starts off as a septum, but is going to end up as extracavitary tissue. And I think it's all to do with the extent of that remodeling as the infundibulum and as the pulmonary root separates itself from the aortic root. And you also noticed that the pulmonary root, in fact, itself spirals around the aortic root. And that, I think, also relates, as you commented, to the origin of the coronary arteries. There's been quite some controversy as to how the coronary arteries themselves develop. And it's suggested that the coronary arteries grow into the arterial roots. I don't think that is in fact the case. When we first see the stems of the coronary arteries, they are arising from the intrapericardial arterial trunks. And it's not until there's further regression of the myocardium that the coronary artery stems are able to make contact with the major parts, the epicardial coronary arteries, which develop within the myocardial turret. So again, it's the separation between the roots, I think, that produces the variation that you see in the origin of the coronary arteries and the way that they eventually attach themselves to how the stems of the coronary arteries, which grow from the arterial trunks themselves, how they establish the connection with the epicardial coronary arteries. But that's something that as yet, I don't think anybody has looked at in any great detail, and it would be a very interesting exercise to see how, we still don't know how they separate one from each other. Very interesting to look at that and see how that impacts on the points you have raised, the origin of the coronary arteries, the alignment between the commissures of the developing arterial valves.
Comment from Dr. Silva.
We have a comment in the chat from Professor Silberbach, one of our preeminent aortic valve experts. Quote, you have published papers about the interleaflet triangle of the aortic valve. Do you have thoughts about the role of the interleaflet triangle and the bicuspid aortic valve?
Absolutely, and that also relates to the regression of the myocardium, because the interleaflet triangles reflect the ingrowth of the arterial wall to become the arterial valvar sinus, and that replaces, as I say, what initially is myocardium, and the arterial wall then grows in to form the valvar sinus, but the tissue between the developing sinuses, which develop in semilunar fashion, becomes the interleaflet triangle. And my colleagues with whom I worked in Newcastle are still doing work on this, and they have shown that the genetic makeup of the interleaflet triangle is quite different from the arterial wall of the valvar sinus. And so is the ingrowth, for the further ingrowth of the non-myocardial tissue that gives us the valvar sinuses. Between those semilunar hinges, we then have the wall of the initial outflow tract, and as the myocardium regresses on the outside, so that wall that becomes the interleaflet triangle itself becomes non-myocardial and has a different genetic makeup. So we're still looking at that in Newcastle, but there is a major difference between the makeup of the interleaflet triangle and the makeup of the arterial valvar sinuses. You ask a very good question about the bicuspid aortic valve, because the bicuspid valve in most instances is in fact trisinuate. But in rare instances, you can have a bisinuate and bifoliate aortic valve, and that reflects failure of formation of one of the valvar sinuses. And we believe that in most instances is the non-adjacent, which develops from the intercalated valvar swelling. The trisinuate aortic valve is then due to fusion between those two of those three primordiums that I showed you that make up the typical valve. And again, we're still looking at that, and we believe that the key to understanding the different types of bicuspid aortic valve is to look at the sinuses versus the leaflets.
Any other questions from the room?
Did you see Michael's other chat?
Yeah. Dr. Silberbach has a follow-up question. What creates the asymmetry of the sinuses in bicuspid aortic valve?
Now that's a very difficult question. I don't think we know the answer to that yet. I think we need more animals in which we can manipulate them to see how the primordiums develop, how they fuse. I'm sure it's all to do with the contributions made by those different primordiums. The primordiums developed from the parietal cushion, the septal cushion, the intercalated valvar swelling, how they differ. But I can't give you a sensible answer to that. All I can do is to speculate that it all depends upon the different contributions made by those components. And as I say, if the intercalated valvar swelling is totally missing, then you get a bisinuate and a bifoliate valve. And we're still looking at that in Newcastle. My colleagues are still working on this, so watch this space.
Dim the lights in the front. Any to think of questions? Any other questions for Professor Anderson? All right, well then, thank you so much, and I think it's a round of applause for Professor Anderson. We can move on to Ms. Spicer.
Okay, so as Bob suggested, I have a normal heart here, and I have my one probe. The aorta is open posteriorly, so this is in the left ventricular outflow tract here, and then I have another probe in the right ventricular outflow tract, so that you can see the angulation between the two arterial trunks here. So pulmonary trunk and left ventricular outflow tract to aorta. And you can also see this very nicely on the short axis view of the heart. So you can see the pulmonary trunk is spiraling around the aortic root, which is here. It's difficult to see because it's a deep hole, but you can see how, as we mentioned yesterday, the aorta forms the centerpiece of the heart, and the right ventricular outflow tract extends anteriorly around, anteriorly and leftward of the aortic root, which then would extend this way. So again, you can see the right angles of the two arterial trunks as they exit the ventricular mass. So I guess we will, since we left off on common arterial trunk, I guess we can start there. I have actually brought a heart that has an aortopulmonary window that looks very much like a common arterial trunk. So if we look at the front of this specimen, you can see here that it looks for, at initial inspection that there is a single trunk coming from the ventricular mass with the brachiocephalic arteries coming off the arch and the arch extending leftward. But when you look at the root of the vessels as they exit the ventricular mass, you can see that there is a small separation here, so that this is the pulmonary trunk or pulmonary root, and this is the aortic root. There is the right coronary artery arising from this. And when this is opened, it looks very much like a common arterial trunk, because this is a very large aortopulmonary window. You can see the left pulmonary artery here and the right pulmonary artery here. But when we look at the valvar structures or the roots within this heart, we can see that there is a separate pulmonary valve and a separate aortic valve. And this is separated by a segment of arterial wall, so that this is not a common arterial trunk, because we have separate arterial valves and separate arterial roots. It's just a very large aortopulmonary window. So just a nice heart to show you how some of these things externally can mimic one another. But once you look at the intrinsic anatomy, they can be differentiated into what they truly are. So this is a very interesting little heart that has a common arterial trunk. There's also some other associated abnormalities. When you look at the position of the coronary arteries, you can see the anterior interventricular here is a bit more anterior than you would expect it, so that there is a hypoplastic right ventricle. And the reason for that hypoplastic right ventricle is that there is the classical type of tricuspid valve atresia. So there is the so-called dimple at the base of the atrial septum. Here is the inferior cable vein, and the superior cable vein is truncated right here. So this is very unusual to have a common arterial trunk with tricuspid valve atresia. So when we look at the hypoplastic right ventricle, you can see there is no inlet, and we have an apical trabecular component and an outlet component. So as Professor Anderson mentioned yesterday, the right atrium is aligned with the right ventricle, but there's no potential for a connection. And here you can see there is a muscular ventricular septal defect. The common arterial valve is supported mostly above the right ventricle in this particular case, and there is a small area of mitral to truncal valve fibrous continuity. As we all know, the truncal valve can vary in how many leaflets there are. I think it can range from 2 up to 5. I can't say that I've ever seen 5, but here we can see that this valve is quite dysplastic. I don't know if I can get a little closer. And the leaflets are somewhat thickened. There is an incomplete interleaflet triangle here. So there's one sinus, a second sinus, a third sinus, and there is a little tiny sinus right in here that's near one of the coronary arteries. So the position of the coronary arteries is pretty significant for the surgeon, depending on where they have to remove the pulmonary trunk or the pulmonary arteries to repair these things, and how close they are to the coronary arteries. So here you can see the pulmonary artery exiting via a common trunk from the posterior aspect of the common trunk. The arch extends to the left, but this is also very unusual that there is this extremely long pulmonary trunk. Here you can see the trachea. There's the right pulmonary artery, and the left pulmonary artery forms a sling which extends around the back of the trachea to the left lung. So this is a very unusual specimen, but it shows us that you can have a common pulmonary artery prior to dividing into the right and left pulmonary arteries that extend to the lungs. And when we look at this from the back, just as some incidental information about cases that have a pulmonary artery sling, they typically have tracheal abnormalities. So you can see there's no pars membranaceae here. There's complete tracheal rings. The trachea is typically poorly formed. And instead of having an upside down Y shape that extends to the lungs, the bronchial component is more of a T shaped related to the trachea. So just those anomalies consistent trachea and bronchial wise with that pulmonary artery sling. So just a nice, really complex example of a common arterial trunk. As you all know, we can have different variations on how the arterial trunks are arising, or how the arterial trunk is arising from the ventricular mass, along with the position and nature of the pulmonary arteries, so that here we can see the right coronary coming from the common trunk here to the right atrioventricular groove. And when we look into the right ventricle, the ventricular septal defect is always an outlet defect. It always occurs between the limbs of the septomarginal trabeculation. And this defect can have a posterior inferior muscular rim. And this happens in the majority of common arterial trunk cases. It can extend to become perimembranous, but in the majority of cases, you will have that posterior inferior muscular bar. And this differs from what we see in Tetralogy of Fallot, where I think 4/5 of those will have a perimembranous VSD, and the lesser amount will have this muscular bar. So here you can see that the common trunk is mostly committed to the right ventricle. So this is also one of the variations we look at. It can be evenly committed to the ventricles, totally to the right or totally to the left. So here again, you can see that this valve has one really nice thin leaflet, and then the remaining two sinuses are guarded by a thickened leaflet that has a fused interleaflet triangle here. So a trisinuate, but bifoliate formation because of that interleaflet triangle. And when we look at the pulmonary arteries arising from this common trunk, they are arising in from a single small common trunk. You might be thinking, what is this hole right here? That's actually the left coronary artery. So this may pose a problem for the surgeon because it's so close to where the pulmonary arteries might need to be resected, to be moved, to repair this common arterial trunk. When we look from the back, it looks as though there are two separate pulmonary arteries coming from this common trunk, but there is a short common segment or common pulmonary trunk arising from the common trunk to the left and the right pulmonary arteries. And here you can see the where is it? The left coronary artery, how high it arises from the ventricular mass. It takes quite a long trek to get from the origin, from the posterior aspect of the common trunk down to the ventricular mass before it bifurcates normally. So there was a short intramural course here as well. So coronaries can create a significant problem in these cases, and so they always have to be adequately assessed as well. I have a couple of cases here from siblings. This family has multiple children with DiGeorge syndrome. And I think these two have passed, and there are two alive, and one sibling does not have DiGeorge syndrome. So they almost look like twin hearts. And as I go through the anatomy, you'll see how similar they are. So here, the right ventricle is extremely hypertrophied. The majority of this common trunk is supported over the right ventricle. Again, it does have a posterior inferior muscular bar. It's very thin in this case, and the VSD is actually a bit restrictive. So here you can see the truncal valve has 4 sinuses, 1, 2, 3, 4, and the valve is quite thickened and dysplastic so that there are some incomplete interleaflet triangles here within this quadrifoliate or quadrasinuate truncal valve. One of the coronaries is behind here, and another is actually quite close to one of the commissures. They're hard to find. The interesting thing about this common arterial trunk, there is sinusal origin of the pulmonary trunk. So this is where the pulmonary artery arises from the common trunk. So very low, almost within one of the valvular sinuses. The arterial branches, brachiocephalic arteries from this ascending component of the common trunk branch quite low. So that this is mirror image branching because there was a right aortic arch. You can see this is the brachiocephalic trunk, the right carotid, the right subclavian. Actually, this is the left carotid because there was distal origin of the left subclavian from this right arch. So a very low takeoff of the left carotid artery. And when we look at the brachiocephalic, or sorry, when we look at the pulmonary arteries as they arise from the common arterial trunk, here is the left here is the left pulmonary artery, and here is the right pulmonary artery. So the right pulmonary artery originates and extends beneath the left pulmonary artery. So this is what we call crossed pulmonary arteries. And this is said to be a rare thing that occurs in common arterial trunk. But the hearts in Gainesville, I have more crossed pulmonary arteries than otherwise. So I don't know if it's something in the water in Gainesville or what. But I have more component of common arterial trunk with crossed pulmonary arteries. I actually forgot to show you one heart in the progression, so I'll come back to it as far as the pulmonary arteries go after I do the sibling to the last heart we looked at. So here, there was a left aortic arch. And when we look into the right ventricle, you can see an even more restrictive ventricular septal defect and increased right ventricular hypertrophy. So you can see nicely how the septomarginal trabeculation has been formed, but a very short cephalic limb, and here's the caudal limb, which is forming that muscular bar. It reaches the ventriculoinfundibular fold in this case, which is that muscle that separates the atrioventricular from the arterial valve. And then you can see again, there is a dysplastic quadrasinuate truncal valve, and this is mostly committed to the right ventricle. One sinus, a second sinus, a third, and then the fourth. Very thickened leaflets with poorly formed interleaflet triangles, and again, a nearly sinuate origin of the pulmonary component. Again, there is the left PA, and crossing under it, here is the right pulmonary artery. So again, crossed pulmonary arteries. And looking at the left ventricular outflow tract of these specimens that have mostly committed the trunk, common trunk, mostly committed to the right ventricle, I mean, you can still easily get out across the ventricular septal defect. But in this case, the defect is quite restrictive. So you can imagine that when these valvar leaflets close, they may even cause more left ventricular outflow tract because of the bulk of the leaflets coapting with the crest of the ventricular septum here with this very small slit-like ventricular septal defect. So let me go back to this little specimen to show you another type of origin of the pulmonary arteries from the common trunk. So here we see the right coronary coming to the right atrioventricular groove in usual fashion. When we look at the valvar leaflets, this case had a trisinuate valve, trileaflet valve with nice, very thin leaflets. This is pretty unusual for a common arterial trunk valve to have all three nice, very functional leaflets. So the right coronary was behind here that I showed you from the outside. There's the left coronary. It's close to one of those commissures. and also close to one of the pulmonary arteries. This is the right pulmonary artery and the left pulmonary artery. And you can see that these arise in separate fashion from the posterior lateral aspect of the common arterial trunk. So just a nice example of separately arising pulmonary arteries from the common arterial trunk. And there they are from the back of this common trunk. And you can see that there was a bit of a high takeoff of the left coronary artery. And you can see how close it is on outward exam to the origin of the right pulmonary artery. So coronaries are definite anatomy that we need to look at. And I failed to mention that there is a posterior inferior muscular bar in this case as well. I have a
For the fellows, really easy to imagine how the pulmonary arteries steal blood flow from the coronaries in this situation, right? Because they're just so close, and that is clinically often a problem with these common arterial trunk situations.
So I hope no one is upset about this fetal specimen that I have. It is a 15-week fetus. There was an omphalocele, so you can see that the liver and the intestine were pulled out into that omphalocele sac. The reason I'm bringing this is because it is the only example I have of a pulmonary dominant common arterial trunk. So you can see the lungs on either side of the heart. This is the apex of the heart. And as we look at the arterial trunk as it arises from the ventricular mass, you can see that it was a pulmonary dominant common arterial trunk. This is the small ascending aorta. And here are the brachiocephalic arteries branching. So there's the brachiocephalic trunk and the left carotid. And here, distal, arising from the descending aorta, is the left subclavian, and there's a little vertebral coming from there as well. So this is the arterial duct. You can see the arch going over the left bronchus. And when I open the right ventricle, you can see the hypoplastic aortic portion here. This is arterial duct, and this is the pulmonary component. So if I can pull this a little forward, you can see those two little slits. One there and one there. And those are where the pulmonary arteries are arising from this pulmonary dominant component of the common arterial trunk. You can see the left one there better than the right. But this case had a solitary coronary artery, which you can see just there. There was no truncal valve, so an absent truncal valve. And the common trunk was supported by a complete muscular infundibulum arising entirely from the right ventricle, with the ventricular septal defect just here. So this, as Professor Anderson was stating, that aortopulmonary septum, when it comes in, it will divide these components, the aorta and the pulmonary components, to different degrees to give more of a septum separating this aortic component from the pulmonary component. And because of the pulmonary dominant component, you typically end up with an aortic arch interruption or a hypoplasia of the aortic arch. So this will just give you a feel for how small these things are in a 15-week fetus when you have a chance to come and look at these things. So the last specimen I have to show you is the one that had the intact ventricular septum. So this, as I mentioned the other day, was an incidental finding in a 37-week intrauterine fetal death. So this was not diagnosed in utero. And when I looked at this specimen in the chest, I saw that there was a pretty big arterial duct, and I saw the aortic arch was a little bit hypoplastic, normal branching pattern. And my initial thought was, oh, this might be an AP window. But as I proceeded, I realized that it was a common arterial trunk. So when we look at the right ventricular aspect, you can see the septomarginal trabeculation, the cephalic arm, and the caudal limb. And the caudal limb is quite thick, so there is that posterior inferior muscular bar. And you can see there were a bunch of nubbins of valvar tissue here guarding the right component of this right ventricular outflow tract. Looking up the left ventricular outflow tract, you can also see that this common trunk was arising pretty much equally above the crest of the septum. So you can see some valvar tissue up in there as well. I didn't open through this because I didn't want to disrupt the valvar architecture. So when we look inside of this common trunk, before we examine the valve a little bit more, there is the aortic component, which is much smaller than the pulmonary component. You can see right there is where it comes off, so that the aortopulmonary septum grew in to this point. And you can see this very large arterial duct communicating with the descending aorta. There was a tiny little juxtaductal ridge just here. So a small little coarctation, if you will, and then the pulmonary arteries branched to the left and right lungs from this pulmonary component. So when I tilt this up, actually let me put my probe in there, you can see where there is a fibrous attachment where the valvar leaflets are joined across the crest of the septum, so an intact ventricular septum. When we tilt this up to look down in on the valve, there is the pulmonary component of the valve, and here is the aortic, or the left ventricular outlet component of the valve, I should say. So right and left ventricular components of this valve. But you can see across that fibrous raphe that's closing the ventricular septum is some valvar tissue joining the right and left components of this common arterial trunk. So this is very reminiscent of what you see in a primum type of atrioventricular septal defect. So that if you compare the two, and I put this kind of on its end, you can see that there would be the left component of the common arterial valve and the right component with the bridging leaflets fused across the crest of the septum. And that's essentially what we have in this particular case. So left ventricular component of the valve, right ventricular component of the valve, and then there's that fused raphe or fused valvar tissue across the crest of the septum, because you can see where that valvar tissue was fused. So
And did this patient have normally arranged other organs?
yes,
Or-
everything else was completely normal.
Would you mind passing the probe of the LVOT through the common trunk? Can you see from the LV aspect?
Pardon me?
Can I see it from the LV aspect? Thank you.
Yeah, you can see that those nubbins of valvar tissue up in there. So those are the common arterial trunk specimens that I have. So we can move on and talk about transposition.
Can I ask a question about trunkers?
Yes,
How often in postnatal parts do you see truncus plus a PDA?
you don't see it that often unless it's a pulmonary dominant. I have seen one case with a relatively balanced combination of aortic component and pulmonary component with an arterial duct. And that's at Medical University of South Carolina. They have that specimen, but that's the only one I've seen a quite balanced component of pulmonary and aortic components with an arterial duct. If it's an aorta dominant, the arterial duct doesn't usually exist.
My second question is, in case of restrictive VSDs in the setting of a truncus, and we have to enlarge the VSD, would you suggest going down the body of the septomarginal trabeculum because I almost feel like if I were to cut across the cranial limb, I might destabilize the valve. Like, do you think the cranial and the caudal limbs are kind of quote unquote holding the valve and contributing to its integrity?
So can you repeat that last about contributing?
The valve integrity. So you see the cranial and the caudal limbs of the
Yes.
septomarginal band. Do you think if I were to enlarge the VSD and cut across the cranial limb of the band, that's going to destabilize the valve?
No.
Did you have a comment, Bob?
I think he's right. I don't think that would destabilize. Where you have the your probe, that's where he wants to cut the cranial limb.
Yes, here.
Yes, exactly. The only thing to worry about is the first septal perforator, which is going to be behind that.
But if I can go down the body of the trabeculum, like body of the band, and enlarge the VSD in that direction, would that be a safer way to do it?
Good point. If you went down, if you did a vertical,
Yeah.
come down, right? Yes, then you'd avoid the first septal perforator probably. So that would probably be the best way to go. But then you're putting the left bundle branch at risk because on the other side,
Yeah.
you've got the left bundle is on the other side. So it's tiger country.
I have a question. I think in the 2011 JTCBS manuscript you and Bob did, there was some variation you found in the VSD types and in common arterial trunk. Could you expand on that and the nomenclature associated?
Well, all of the VSDs are outlet ventricular septal defects.
So you call it an outlet even if it, it sounds like some of the specimens you examined had erosion or hypoplasia of that inferior caudal limb. You'd still call it an outlet?
Yes, it would be an outlet VSD because they are in between the limbs of the septomarginal trabeculation, whether the caudal limb is absent or, as in most cases of common arterial trunk, it's typically intact. They can extend to become perimembranous, but then that would differentiate whether it was perimembranous or just an outlet defect with a posterior inferior muscular bar. And of course, you can have those defects that will extend into the inlet component, but they're still outlet defects with inlet extension, which we would call a confluent VSD, but the nomenclature group has not yet accepted that term. So you can have variations in the extension or the geography of the VSDs,
Right.
which will also impact the conduction system if it extends into the inlet. It'll push it more posterior inferior.
So if it was a,
Yeah.
You can also get coexisting muscular defects. So
Right.
the defect Diane has shown is juxta-arterial, and in fact you can compare that to you showed them juxta-arterial defects yesterday, presumably, Diane.
Yes, and I actually have one in a transposition here.
So the juxta-arterial defect is when the separation of the artery, the outflow, the arterial roots are separated and they are then fused with the aortopulmonary septum. So there you see the raphe at the top of the defect. And so that is also is comparable to the defect we're seeing in common arterial trunk, but in this instance with separated arterial roots.
Yeah, so they occur very much in the same spot. But just
Exactly.
as Professor Anderson said, we have separate arterial roots with the juxta-arterial VSD. And here, this one has a posterior inferior muscular bar as well.
So for just to repeat it back, make sure I understand. So in a common arterial trunk, the VSD would be described as outlet, and if there is a fibrous inferior margin with kind of hypoplasia of that inferior caudal limb, you'd call it outlet with paramembranous extension.
Yes.
Okay, thank you.
Or a juxta-arterial.
Diane, before we move on, for truncus, have you seen a sinusal single PA with the second PA that wasn't low down in the sinus, or is it typically, root cause or just a single?
Well, I don't think I've seen separate, like one with a sinusal origin and one with a higher origin. I haven't seen, I don't have a case like that. I'm sure they exist. Because if you look in the literature with common arterial trunk with intact septum, there's a number of cases that are reported, but the pulmonary artery anatomy is different in a number of them.
The other thing you should mention, Diane, is when you get the the persistently patent duct with aortic dominance, when you have discontinuous pulmonary arteries, and in then one of the pulmonary arteries can arise through the arterial duct, which is the
Right.
other variant in which you find persistence of the arterial duct.
And actually, I have only seen two cases. We talked about this a little bit the other day, common arterial trunk with pulmonary atresia. Those cases can have a duct as well. And the case that we found when we were cataloging the collection in Phoenix was diagnosed clinically as tetralogy of Fallot with pulmonary atresia because there was a duct. They stented the duct, and the anatomy clinically was consistent with that because the common trunk was overriding the septum, the VSD was beneath the aorta, and they could see the branch pulmonary arteries feeding from the duct. But when we looked at the heart as a pathologic specimen, you could see that the atretic pulmonary trunk was coming directly back to the ascending component of the common trunk. So clearly, the clinical and pathological diagnoses were different, but for all intents and purposes, the patient was treated correctly to try to get to repair. So I've seen two cases, one that my friend Rohit had in Chicago and the one in Phoenix. So we actually wrote those two cases up recently. So unusual things that you can see. And like I said yesterday, if you don't look, you're not going to find them. So if we move on, we don't have a whole lot of time left. We spent more of our allotted time on common trunk than I thought we would.
We have 30 minutes between now and the arch talk, so you can feel free to go along.
Oh, okay. Well, let me get through transposition here really quickly. So this is a heart that I don't get too much anymore because of the increased scanning in utero. But you can see, we're going to talk about the position of the arterial trunks as they leave the ventricular mass in transposition. So here you can see the aorta is anterior and rightward of the pulmonary trunk. The aortic arch was extending to the left, and there was a barely probed patent arterial duct. When we look into the right atrium, you can see at the floor of the oval fossa, there's quite a thickened, corrugated atrial septum. There's our coronary sinus. So this was actually a premature closure of the oval fossa. Tricuspid valve, intact ventricular septum, the aorta arising from the right ventricle. There's a coronary, there are brachiocephalic arteries identifying this as an aorta. And when we look at the left ventricular septum, you can clearly see that it was intact. And the left side of the atrial septum again shows us that thickened, kind of corrugated, almost a little bit aneurysmal atrial septum. So there was premature closure of the oval fossa. As I mentioned, a very small, I can just push my 2 mm probe through that duct. And so this baby was born at an outside hospital and immediately was in trouble. And by the time they got it to UF, it did not survive. So this was a diagnosis that was not made in utero. So this patient couldn't have an emergent atrial septectomy to get it to repair. So just 2 complete circulations in this specimen, systemic, back systemic, because there was no interatrial or interventricular communication, and then pulmonary back to pulmonary, again, because of no availability of shunting.
Diane, so is it usually premature closure of the atrial septum that gives that thickened appearance? Because I feel like we see that thickened appearance on echo with transposition not infrequently.
I have seen it both thickened and not thickened.
Okay, sure.
So I guess it just depends on the developmental process in each fetus. But I've seen it both ways. And I've seen it quite aneurysmal as well.
So the ones we see are pretty flimsy.
Yeah. I just feel like sometimes we do see those one thickened, and then we have to prepare, obviously, the interventionalist for this thickened on the go press.
So this is another transposition that Dr. Van Merup had windowed. And here's the flat valve at the floor of the oval fossa. And you'll note that here in that interatrial groove, Waterston's or Sondergaard's groove, there are some sutures. So this is a specimen from probably the 70s where they did a Blaylock-Hanlon atrial septectomy or removal of that interatrial fold to create more shunting at the atrial level. And when we look into the right ventricle, we can see clearly that the aorta, there's a coronary, arises from the right ventricle. And this shows us one of the coronary issues that you can have with transposition, so that the right coronary is arising from the left facing sinus, or the right facing sinus, because it's transposition, and extends across the front of the aorta to reach the right atrioventricular groove. So because there are coarse trabeculations within the right ventricle, we have to look extra hard for our ventricular septal defect. So ventricular septal defects in transposition can occur the same places as when you have concordant ventricular arterial connections. So this one had a mid-septal ventricular septal defect that was entirely surrounded by muscle. You can see it a bit better from the left side, and this was not a very it was probably a very restrictive ventricular septal defect and may have actually closed over time. The other point I want to make is that this specimen has bilateral subarterial muscular infundibulums. So you can see that the mitral valve is here, the pulmonary valve is here, and that there is muscle between the atrioventricular and the arterial valve. So in the old days, a lot of people would argue that if you have bilateral infundibulums, you have a double outlet right ventricle. But clearly, in this specimen, the aorta comes from the right ventricle and the pulmonary artery from the left ventricle. So you can have bilateral muscular infundibulums and have different ventricular arterial arrangements other than double outlet right ventricle. You can see that this patient also had a pulmonary artery band. And if we look at the arterial trunks, the aorta is actually more anterior, directly anterior to the posterior pulmonary trunk. This is that heart I promised you yesterday that has the aorta rising to the left of the pulmonary trunk. So we can see outwardly, this is the aorta. It's clearly anterior and leftward of the pulmonary trunk. You can see the right coronary coming here. There's a very large infundibular branch, and this case has a very tiny anterior muscular VSD that probably was not helping with anything, and a very dilated left ventricle. But I brought this specimen just to show you that you can have different rotational relationships of the arterial trunks as they leave the ventricular mass. And so this would be SL and not SD as far as Van Praagh goes. Even though it is, pardon me?
SDL.
Yes, SD, yes, SDL. So instead of SDD, but we still have regular transposition. So there are multiple different types of VSDs we can see with transposition, and I will quickly go through them. This heart actually has the aorta anterior and somewhat leftward of the pulmonary trunk. You might look at the right atrium and think, oh, it looks morphologically normal, but it looks pretty tiny. There's the superior cable vein. And when we tilt the heart to look at the left lateral aspect, you can see that there's juxtaposition of the atrial appendages. So this is the rest of the right appendage, which has been pulled posterior to the arterial pedicle and lies now a little bit above the morphologically left appendage. So this specimen has, in addition to the juxtaposition of the atrial appendages, it has a central perimembranous VSD. So right up in here is a tiny ventricular septal defect. You can see that the inner heart curvature has inserted normally between the limbs of the septomarginal trabeculation. And here is the medial papillary muscle, which is in its typical position relative to the borders of this VSD, which is in a little bit more anterior and superior position. The VSD is better seen from the left side. You can see how tiny it is. That's tricuspid valve. There is probably a little remnant of membranous septum here. So those tubercles that we talked about of the atrioventricular cushions did not quite close this tertiary interventricular communication. And you can see that there was clearly muscle here between the pulmonary valve in this case and the tricuspid valve. But a very tiny little area of fibrous continuity here between the atrioventricular valves. So a central perimembranous VSD. You can also have, in addition to mid-septal muscular ventricular septal defects, you can have outlet ventricular septal defects that are entirely muscular. So this, I've removed the free wall of the right atrium, right ventricle, and the aorta, and you can see the oval fossa was intact here, and this is most likely a vestibular atrial septal defect. There's the coronary sinus mouth, and you can see the aortic outlet here with a subaortic outlet ventricular septal defect that has entirely muscular borders. So there's a posterior inferior muscular bar here, which would be protective of the conduction tissue. The pulmonary trunk overrides slightly in this case, and as in a couple of the other cases, the aorta is a bit anterior and leftward of the pulmonary trunk. When we look at the right ventricular outflow tract, you can clearly see that there is a muscle bar between what would be the tricuspid valve and the mitral valve. This is the case that I mentioned a little bit about yesterday that I meant to have in our mitral valve segment, because this case has a supravalvular ridge or ring within the left atrium, which is actually above the valvular hinge point. At most of its extent, it does extend onto the hinge point just here. So this was a very interesting case of transposition with a supravalvular mitral ridge. And the valve was a bit thickened, and there was even a little bit of a cleft in this mitral valve. So interesting combination of things that you can find even in hearts with transposition. So this is another heart that's been windowed by Dr. Van Merup. You can see that there's a small deficiency of the flat valve at the floor of the oval fossa, and there is a perimembranous ventricular septal defect. This again is an inlet ventricular septal defect, and there is some degree of subaortic stenosis in this case. The outlet septum is a bit prominent and hypertrophied. The aorta again is almost directly anterior to the pulmonary trunk, a little bit leftward. And when you look at this defect from the left side, you can see that there is a remnant of the membranous septum here, and there is fibrous continuity in this area between the atrioventricular valves. We already looked at the doubly committed and juxta-arterial ventricular septal defect, and just like the one we looked at in the VSD segment, there is fibrous continuity at the roof of the defect between the aortic valve and the pulmonary valve now coming from the left ventricle. And this one does have a posterior inferior muscular bar, so they can extend to become perimembranous. And this is as a result of hypoplasia of the outflow cushions during development, so that the arterial trunk arising from the right ventricle does not get lifted up off of the right ventricular mass, and the arterial valves remain at the same level. There are different scenarios you can see in transposition where you have outlet septum malalignment. So this specimen, I actually sewed back together because it was opened incorrectly. And you can see that there was an atrial septal defect. There's a few fenestrated remnants of the flat valve here. This is the mouth of the coronary sinus. And when we look into the right ventricle, there is a ventricular septal defect here. It is a muscular ventricular septal defect with part of the tricuspid valve supported in the left ventricle. Sorry, that was my alarm that doesn't want to go stop. Okay, sorry. All right, behave. So this part of the tricuspid valve is in part supported across the muscular VSD into the left ventricle, and we'll see that in a moment. But here we have very much the same situation of what we see in tetralogy of Fallot, so that there is anterior malalignment of the outlet septum, which is giving us aortic stenosis rather than pulmonary stenosis because we have transposition. So if we look at the continuation of the aorta, it was a left arch with normal branching from the arch. And here you can see the transverse arch to the isthmus becomes very tiny. That's the left subclavian. And when we look at it from inside of the arch, You can see the tiny opening where the isthmus joined the descending aorta. This is pulmonary trunk, and this is arterial duct. And you can see the difference in coloration when formalin fixation happens. It changes the color of the duct, so we can see where the extent of the ductal tissue is. So if this duct closed, this aortic opening is in the middle of ductal tissue and would have become hemodynamically interrupted. So anterior deviation of the outlet septum. This specimen also shows us nicely some of the other substrates that can cause left ventricular outflow tract obstruction. So here is that straddling component of the tricuspid valve. So valvar tissue protruding through a VSD into the outflow tract can be one substrate for obstruction. And you can see here that there's a very thick subpulmonary muscular infundibulum, and it's separating the mitral valve from the pulmonary valve. So this hypertrophied subpulmonary infundibulum is also a substrate for subpulmonary obstruction or left ventricular outflow tract obstruction. Another substrate for that are those defects that we see with posterior deviation of the outlet septum or malalignment posteriorly. Again, a perimembranous VSD with fibrous continuity between the tricuspid and mitral valve along the posterior inferior border, a very short subaortic infundibulum. And when we look up the barrel of the left ventricle, you can now see that outlet septum here pushed quite posteriorly into the pulmonary, subpulmonary outflow tract. There was the outlet septum here is a muscular bar. There's the perimembranous VSD, and the pulmonary valve was bifoliate in this case. One leaflet which was cut, and there's the second leaflet there. So yet another substrate for left ventricular outflow tract obstruction. And by the way, any of these things that cause left ventricular outflow tract obstruction in the normal heart can also occur, as we see in those hearts with transposition. So this was a specimen that had an arterial switch and eventually went to transplant. And you can see that I've removed the free wall of the left ventricle. And here, this shows us that the subpulmonary region was developing a left ventricular outflow tract ridge in the subpulmonary region. You can see that these can sometimes involve the valvar leaflets, and they can also extend on to the mitral valve. This one isn't very extreme, but if left go, it may have developed into a much more stenotic situation. The other interesting thing in this specimen is that both of the coronaries arise from the same sinus. So there is the right coronary, and the left coronary arises here, just at the commissure between the right and left facing sinuses relative to the pulmonary trunk. So there's a short intramural course of this left coronary across this commissure. So I didn't have the chance to bring all of the coronary variations that we can see, but I did bring a specimen that has the arterial trunks cut on short axis. So this is the sternocostal aspect, and this is the aorta, the pulmonary trunk. This was an intrauterine fetal death. That's why the pulmonary valve is so dark. But you can see if I stand in this non-adjacent aortic valvar sinus, we have the right hand facing sinus here and the left hand facing sinus here. So the left hand facing sinus gives rise to the right coronary, and the right hand facing sinus to the left coronary. And if we look at the commissures here, you can see that this commissure does not match up with this commissure. So that there is a little bit of commissural mismatch in this particular heart width transition. And this is sometimes affecting where the coronaries are going to be moved in the arterial switch, because the closest position would be right here adjacent to this commissure. So surgeons are very good at these days at realigning these things and moving them in appropriate fashion, but it does happen where things have to be looked at in order to get the coronaries to the right position. I have a couple of repairs that you guys are free to look at whenever we have some hands-on time, but I'm not sure how much time I have left, Patrick. But,
About 15 minutes.
okay, we'll have to swing pretty quickly through DORB then. So I will show you,
It's pretty simple.
I will show you some of the characteristic things that we can see with double outlet right ventricle relative to the arterial trunks and the interventricular communication. So here we can see the window, the right ventricle and the arterial trunks were kind of cut away anteriorly. And you can see there's a nice prominent outlet septum between the pulmonary trunk where there's no stenosis and the aortic root. And there is a subaortic interventricular communication, and it extends to become perimembranous. So there's fibrous continuity between the tricuspid and the mitral valves along the posterior inferior border. So this is one of the more common types of ventricular septal defect, or I should say interventricular communication in the subaortic region. And some of the points that Professor Anderson made about the development is this area where my probe is actually the area that forms the left ventricular outflow tract or that secondary interventricular communication. So this is the VSD, and this area, if that area was closed, the surgeon would actually block off the left ventricular outflow tract. So this area will be what the surgeon will close to tunnel the aorta back into the left ventricle. And so they will close the interventricular communication rather than closing the VSD, which is now forming the left ventricular outflow tract. This is a similar case, but with just some added trouble for repair. You can see the right ventricle is quite hypertrophied. The pulmonary trunk here is without stenosis. There's our outlet septum. And the interventricular communication is again in the subaortic position. It's quite restrictive. And there are tricuspid valve tissues crossing the outlet to this aorta. So this ended up with an interrupted aortic arch. Here you can see the brachiocephalic trunk with the carotid and the subclavian, left carotid, and there you can see the left subclavian back here joining with the duct joining the descending aorta. This case also had a very high origin of the left coronary artery. So multiple things can be seen which need to be described in these patients. Other common variations of double outlet right ventricle are those that have more phenotypic features like tetralogy. And so the two can coexist. And here again, the free wall, the right atrium and ventricle have been removed. You can see that there's quite an elongated outlet septum and an elongated narrow subpulmonary infundibulum. If I tilt the heart upwards, you can see that most of the aorta is committed to this right ventricle with only a small portion committed to the left ventricle. So greater than 50% of the aorta arises above the right ventricle. This VSD is an outlet defect that extends to become perimembranous here along the posterior inferior border, which is typically the case in those hearts with tetralogy phenotype. And the nice thing I'd like to point out here, as we've talked about, malalignment of the outlet septum and the formation of the outflow cushions, is you can see clearly there is a component of subpulmonary muscular infundibulum here that joins with this prominent outlet septum. So that when those cushions become divorced from joining with the apical component of the muscular ventricular septum, you end up with this prominent right ventricular structure. And the aorta fails to move to different degrees into the left ventricle. But you can see a nice component of the subpulmonary infundibulum here that is separate from the outflow septum that's now prominent. You can have different degrees of the outlet septum in these cases. So here is the aorta, and you can see the pulmonary trunk is here, so that the aorta is extensively anterior and rightward of the tiny pulmonary trunk. So clearly mostly submitted or committed to the right ventricle. And what I want to point out is this also has the tetralogy phenotype. So there is our subpulmonary outflow tract, but look how short this outlet septum is, so that you can have different degrees of outlet septum. It can be very short. It can even extend to become fibrous, and it can be quite long, like the last specimen. Here, the ventricular septal defect has a posterior inferior muscular bar. And just hopefully I can get this guy to show up. So this is the only heart I have in my collection with this anatomy. So the aorta, you can see clearly, is totally committed to the right ventricle. There is the ventricular septal defect. It extends to become perimembranous. And the pulmonary trunk is here. And you can see on my forceps that there is a fibrous outlet septum. So that this case is of the tetralogy phenotype with a fibrous outlet septum between the two arterial valves. And you would not call this defect doubly committed and juxta-arterial because it is in the subaortic region, and there is a fibrous outlet septum between the pulmonary trunk and the aortic valve. So it's a tiny heart, but it served its purpose. And this was probably from maybe a 17-liter. So you can have double outlet right ventricle, where you have both arterial trunks arising from the right ventricular mass with complete muscular infundibulums. So here, that is the case. When we open up our arterial valves or arterial roots, you can see there's a complete muscular infundibulum supporting the aorta and a complete muscular infundibulum with some pulmonary stenosis supporting the pulmonary trunk. The ventricular septal defect in this case might be one that you would call remote or non-committed. It's an inlet defect that extends to become perimembranous. There may be surgeons who would think about how they could tunnel this to put either of the arterial trunks back into communication with the left ventricle, but these tricuspid valve tendinous cords and leaflets may be in the way. This case had a smallish left ventricle with mitral valve dysplasia, and you can see that defect here is extending into the inlet component and towards the apex. So quite a large VSD, but one that some people may call remote or non-committed. This is another very nice little specimen that shows, again, 200% commitment of the arterial valves or arterial roots leaving the right ventricle with bilateral subarterial infundibulums, a very large right ventricle, and there was atresia of the mitral valve, so a blind ending floor to the left atrium. And when we look at this tiny left ventricle, the way it was incised was too deep within the right ventricle. So this is artifact. This wall should be here. There is the tiny ventricular septal defect that is in subaortic position when we look back into the right ventricle. Or actually, it's kind of remote in this specimen now that I look at it. So very tiny ventricular septal defect and nearly an intact ventricular septum, which we can see in this last specimen, which was a cardiac explant. So I have it cut in a 4-chamber plane, but looking into the floor of the left atrium, there was very little of cavity for the left atrium. And looking into the floor of the aorta, you can see the valve is imperforate. And when we look at the 4-chamber cut, there is an imperforate mitral valve here. You can see the little dome-shaped piece of mitral valve where it was imperforate. The septum was intact. There was a hypoplastic left ventricle. Here, there's the other half of the imperforate mitral valve. And when I put a probe into the aortic valve, you can see it lies just behind the tricuspid valve here. And so it was mostly committed to the right ventricle, along with the pulmonary trunk here. So there's the imperforate aortic valve and the pulmonary valve. So this was a double outlet right ventricle with an intact ventricular septum and imperforate aortic and mitral valves. So we looked at the double inlet, double outlet ventricles yesterday with respect to the mitral valve straddling. So those are here to look at again, but I don't think I need to show them again since we're short on time. Whew. Sorry, that was. Sorry if I cut into your time, Professor Anderson.
I don't think you have. I don't think we start till 5 o'clock my time, so you've still got 5 minutes.
And I could get a call?
Well, any questions for Mr.
Yeah.
Is it possible to have intraventricular communication but not a VSD, like the atrial equivalent? You know, we talk about interatrial communication, which are not ASDs.
Without an ASD?
No, just, on the atrial level, we talk about interatrial communication that are not ASDs.
Ah,
So is there an equivalent on the ventricular level?
it all depends on what you call the VSD. But it's a good question. Can you get a communication between the ventricles that is outside the ventricular septum? We'll have to think about that one. You've given us something to think about there. I think it would have to be something at the aortic root level. But I'll have to think about that one. I've not thought of that one before.
I've noticed both Professor Anderson and Dan seem to prefer the term bifoliate, trifoliate. Is there something imperfect about the word trileaflet, bileaflet, bicuspid?
No, the trouble is that cusp is currently used interchangeably to account for either the sinus or the leaflet. I have no problem with bileaflet, trileaflet. I just find bifoliate to be more elegant. It rather slips off the tongue better.
We all aspire to elegance, so.
Yeah, and it's one of those things that over 44 years of being with Professor Anderson, many terminologies have changed. And now we're trying to reorient people from calling things a cusp. And so I am working very hard in my own mind to say either tri-leaflet or trifoliate. So sometimes both terms come out when I'm trying to, reprogram my old terminology from cusp to leaflet.
Dr. Tretter prefers leaflets, so
Yes.
he doesn't like foliate. So we'll distinguish sinuses and leaflets, and in that respect, I guess bileaflet, trisinuate makes more sense. So
Yeah.
I'll give up on the foliate.
Well, I'm not trying to push you.
Me too.
We'll stick with leaflet.
All right, leaflets are okay.
Leaflet's okay. Just avoid cusp. Are infundibulum of conus synonymous? It depends on how you identify the conus. That's another problem because, I mean, the problem that we discussed Kramer's contribution. He never told us. He never identified what he thought was the conus. I just find infundibulum easier to cope with, but I think essentially they are the same. I think the conus is the same as the infundibulum.
All right, I'm gonna give people 2 or 3 minutes to get their coffee, and then we'll start the next session.